Now we are on. I think we need to start straight away. Thank you all for attending this session. We're going to start off with the keynote speaker, Dr. Denis. Could you please share your screen and start the presentation? And it should be for no longer than 15 minutes or less, because we need to catch up. Sorry about that.
I think I was given 20 minutes, so I request that I stay within my time.
Okay, try and make it 15, because we want to catch up on time.
Thank you. Thank you, Dr. Gladys. I'm very glad to have been invited to make this presentation. I will try to be as brief as I can and leave out most of the concepts that have been shared already, and go straight to the key messages that I want to share with you.
Thank you.
I will show my face so that people can relate the talk with the person. So thank you very much. So I will give my keynote address. Just 1 second, please. Yeah, I'll give my talk about, in the context of One Health, relating to MR. And I will review some of the concerns together with the background, and then concentrate on some of the examples of the MR work that we have done in Uganda. Finally, I will discuss some of the possibilities of retarding MR resistance and make our conclusions. So as we well know that microbiomes are in all environments and they live under competitive phenomena, and this creates a pool of antimicrobials and resistance in equal measure. Soil continues to be the source of most of the antibiotics, including the recent antibiotics like teicombactin, and these skills has been found to be useful in some of the in killing some of the resistant bugs like MRSA and MTB. The environment also plays a very significant role in the maintenance and spread of antibiotic resistance, and I'm particularly very glad that the Minister of Environment is taking up very keen interest in this, and I welcome them on board like everybody else. Increasing evidence of sharing of organisms between different systems in an ecosystem. There is a lot of evidence that currently is available to emphasize this fact, and therefore we need to ensure that in our interventions, we clearly take cognizance of these different sources and their potential in spreading resistance. The major concerns with the resistance relate to some of the very key organisms. We all know about the MTB, the MDR malaria, and the HIV resistance, which are some of the major public health threats that relate to antimicrobial resistance. But recently, there's a lot of concern about MDR bacteria. And of these, I've tried to pick out some of them, including the resistance of E. coli to 3rd and 4th generation cephalosporins and fluoroquinolones, because these resistant ones will have very limited options for treatment. There are also concerns about Klebsiella pneumoniae that is resistant 3rd generation cephalosporins and carbapenems. And for Staphylococcus aureus, the concern is those that are resistant to methicillin. But also with regard to Streptococcus pneumoniae, there is concern for those that resist penicillin, for Shigella against fluoroquinolones, and this morning there were concerns about Neisseria or gonorrhea, and resistance to 3rd generation cephalosporins is also a very major concern relating to how these resistant bugs will be treated. Going forward, why are we bothered? The reason we are bothered and the reason we are making sure that we make a lot of noise is because most of these resistant infections are are more difficult to treat. They require drugs that are not readily available. They cost more and longer treatments, in addition to longer hospitalization. But also some of the alternative drugs are actually sometimes toxic, and we may at some point run out of alternative drugs for their treatment. Now, this is where the rubber meets the road. You have the hotspots that include the hospital environments, where everybody who goes there, probably more than half, are receiving antibiotics. You have the farms where all the sick animals, probably more than half, also get antibiotics. And you have the environment. You can see this drainage channel here. If you are in a place like Katanga, you know this is probably part of it is coming from, might be leaking from the hospital. But you also have very poor sanitation. That means that everything that the people living in those areas are taking is ending up in the environment. Children might be playing in those places, and you may have a very serious catastrophe. This is a very common epidemiological transmission cycle for MR, demonstrating the connectedness between the different niches, the human environment, the environment, and the animal sector, where we use drugs for several things. If you look at this picture in a hospital, typical of the Ugandan settings, when there is high incidence of certain infections like malaria during the rainy season, you find a situation like this. And if you can imagine any of these patients being sick with the resistant organism, it means each of these individuals is probably going to pick that organism and perhaps take it back home and spread it within the community, within the family, and also give some to the animals. And this is why we are really highly concerned. So globalization, of course, has spread all these organisms everywhere, and you all know everywhere you travel, you take some of the organisms with you and you bring us back some of them. And this spread into the community, the hospitals, and we have all this, and it's a common phenomenon, and we cannot run away from it. So I will quickly go to some of the studies that we have done. I think it makes more sense. And I will probably specifically talk about two of our studies, and then I will relate to some of the other studies that we did earlier, so that we can have a comprehensive overview of some of the data that is available. But at the same time, we look at the implications and how we can use some of this information for formulating appropriate evidence-based interventions, so that we can begin to use evidence to recommend interventions that our policymakers can use to contain the problem. So we did an MR transmission dynamic studies in Masaka, and I want to acknowledge support from the Makerere University Research and Innovations Fund, funded by government. And our objective was to establish the transmission dynamics of MR between different sources. So we picked samples from patients, from caretakers, from healthcare workers, from hospital environments, household animals, household environment, and household contacts. And we screened these samples by screening them on extended spectrum beta-lactamase medium and carbapenem resistance. So all the isolates were screened again on this media, and then the isolates, in other words, those that were ESBL or resistant carbapenems, were subjected to susceptibility testing, and we also selected some of these for whole genome sequencing. In total, we collected over 1,000 samples, and we isolated over 1,000, almost 2,000 isolates. We've so far subjected 742 of these to susceptibility testing, and these include 211 samples from index patients, 35 from caretakers, 54 from healthcare workers, 184 from the hospital environment, 65 from household animals, 126 from household environment, and 71 from household contacts. So this was able to give us some view of exactly what was happening within these different compartments, but also how they were being transmitted between the different compartments. This is a general resistance. As usual, we see very high resistance antibiotics. And here we are looking at some of the antibiotics. I think I should have expanded this, but it generally tells you that we have a very high level of resistance. Of course, this is a little bit biased because we selected those that were already resistant to cefotaxime, which we used as a screening agent for our ESBL, and of course the others for to have very high resistance to ESBL and CRE up to a level of 21%. But we also have resistance to fourth generation cephalosporins, and we used kefepime for this, and this is well above 70%. Most importantly is that these are significant isolates that were resistant to either one or more of the WHO highest priority list of critical important antimicrobials. And these include the third, the fourth, and fifth generation cephalosporins, macrolides, and quinolone, some of which I showed you in an earlier slide. This was done, as I mentioned, in Kitovu and Masaka. Not, of course, it's an upcoming city, but roughly out of the city. These are the type of phenotypes related to what we find. You can see, that some of the isolates, up to six of them, for example, here, are showing a phenotype for all the antibiotics that you screened for. What this, in common language, what this means is that probably this patient did not have an option for treating the infection with these bacteria that were causing the infections. And actually, because we did not have funds follow up some of these, but we got information that some actually of these patients passed on. We are not sure whether they passed on because of these resistant infections, but it's also very high likely that this could have been the reason why they died. And we hope that given additional funding, we should be able to follow up some of these and determine whether, or the extent or the burden of resistance, to look at how much time people are spending in healthcare settings because of resistant infections, and what does that translate to in terms of the cost that the hospital bears looking after these patients that have got resistant infections. We compared resistance between the different sources, and as expected, we found that there was higher resistance that we found in healthcare workers, in the healthcare environment, and surprisingly, we also found high resistance in household environments. While we expected that we should find high resistance in healthcare workers, because they are always in this environment that is exposed to antibiotics, and certainly the healthcare environment, we did not expect to find high resistance in household environments. What this means is that some of the patients might come into hospitals already having carriage of highly resistant organisms and probably potentially spread them into the healthcare facilities. And also when they are going back, of course, some of them will take back some of these highly resistant organisms from the hospitals. And therefore we have this cycle of highly resistant organisms coming from the healthcare facilities going into the communities, and also coming from the communities into the healthcare settings, and of course, transmission within the different niches. In terms of multi-drug resistance, we see a very high level of resistance to almost 15 and above, but we have the highest resistance of isolates that show resistance to 11 to 15 drugs. If you look here at the cumulative frequency, we see that 12% of the isolates were resistant to 15 to 18 antibiotics. 72% of the isolates were resistant to 10 or more, but more critically, you can see even up to 95% of the isolates we got, the bias notwithstanding, were resistant to 5 or more antibiotics. And certainly this has a lot of implications on the effectiveness of the antibiotics that are being utilized to treat these patients, or probably if any of these was a patient or their caretakers and they fell sick, this would have a lot of implications. From our whole genome sequencing, we found that by single nucleotide polymorphism, or SNP analysis from the whole genomes of up to 47 E. coli strains, this revealed a very high diversity between the different isolates. So there were so many different sequence types of these organisms, but also it revealed a potential for transmission between the different sources. We are still doing further sequencing on these isolates, and when we get more data, it should clearly show the potential for transmission between the different sources as demonstrated by the phenotypic analysis. Now, the key messages from this study, it clearly indicates that there are hotspots for immediate focus of intervention, and these include the healthcare workers who are routinely within the hospital, the healthcare environment, but also surprisingly, the household environments. And we need to make sure that we can take immediate and vigorous implementation of the infection and prevention control guidelines. Unfortunately, or strategic objectives, IPC is one of those that has not received sufficient support. And yet, this is one of the strategic objectives that will actually minimize transmission, as we have seen, between these different environments and curtail transmission. And we have generated data to support for this. And also we can be able to monitor the impacts of these interventions on curtailing transmission. We have also demonstrated that there is need to integrate One Health approaches to curtail this transmission from the environment, from the animals, and the humans themselves. We have not reached a level where we can do directional transmission so that we know whether it's the humans that are the culprits that are transmitting this into the environment, or the vice versa, or the other way around. But hopefully we should be able to get there sooner than later. The other data that I would really want to share with you is our MURAP Emr Surveillance activities. I know there were not specific.
I just wanted to say you have just 2 minutes to go.
I will rush through this. So we have been doing surveillance for the last 12 years on a very, very small scale, even before the NAP came in. And we've been working in 4 regional or district hospitals, Gulu, Kirudu, and Bombo. And we also collect isolates, we do susceptibility testing, we do whole genome sequencing. This is the general picture of the resistance, not different from what we saw in Masaka. And that's not really very surprising, because these are more or less the same settings. But also do whole genome sequencing. And here you can see the multiple resistant genes that we find in each of these different isolates. But we can also see, I don't know if you can see my arrow, some of the common resistance genes across all the different isolates. And we can also see the relatedness of these isolates, including some of the common serotype sequence types like the ST131. And we did these for Klebsiella pneumonia. We see the same patterns. We identify the genes that support the phenotype. We did this for the Salmonella Staph aureus. We did this for several different organisms. And we have also identified very high virulence factors for some of these isolates that are related to adherence protection, adherence proteins, plasmid-encoded enterotoxins, as well as secreted autotransportation toxins that make these isolates more resistant. And some of these are carried on plasmids, which sometimes can jump from one bacteria to the other. Now, the key findings from this is that there is also high resistance to common antibiotics. We see an MDR expect ST131, the CTX M27. This is a very notorious strain that was first reported in Japan and highly resistant for quinolones and cephalosporins with very highly virulent factors and spreading globally. And we need to intervene to make sure that this doesn't spread and establish within our healthcare settings. And of course, the usual MDR, Klebsiella serotypes, the sequence types, and MRSA. Now, I will just rush through the other studies. This is one of our old studies about resistance in different food animals. This was in human, non-human primates. Fortunately, we don't see high resistance, for example, to meropenem, we found 0. But we could see some of the resistance, particularly to some of these antibiotics that are known to be within the environment. And of course, for conservation medicine, including the chair here, you need to take keen interest in some of this information that we have this resistance building up within the animals that are not ideally treated. During my other trips, I picked several samples from other animals. We picked samples from elephants, from hippos and buffaloes. And again, we don't see resistance to cipro and gentamicin, but we see resistance in some of the isolates, not very high, but some of them. Of course, we know for Pseudomonas, there might be some natural resistance, which we acknowledge, but at least beginning to generate information from different sectors to ensure that we can provide data to interventions and ultimately determine how these organisms are being transmitted. Gladys, if you can give me 2 more minutes. From our Salmonella studies, this is work that we did with Mahero from one of our collaborating institutions where we were comparing humans and cattle samples. Again, you see the resistance is not really very different. It means that the resistance in animals and humans could be potentially the same. We saw some common serotypes between humans and chicken here, the sequence type 356, although the others were largely different. But that serotype indicated probably that it is being shared between humans and the chickens. We also did some sampling from the Nachivubo channel in Kampala here, and we demonstrated resistance in some of the serotypes that had specific sequence types in poultry. And we also demonstrated the relationship. If you look at the colors here, this red is for human clinical samples. The dark blue is from the human influent. We sampled from different sewage treatment plants along the Nachivubo channel. What was amazing here is that even the water that is coming out of the effluent treatment plants, some of them have got isolates, Salmonella typhimurium, that is demonstrating MDR. And that should be a cause for worry because this is being discharged into the environment as clean material that is just being discharged. So there were shared serovirus and microbial resistance patterns and genotypes suggesting dissemination of non-typhoidal salmonella between these different sources. The most common threat was this DECA-resistant Salmonella Kentucky that was mainly found in chicken. And given our chicken preparatory kind of systems here, it could be a source of foodborne illnesses in some cases. I just wanted to show you that similar studies done elsewhere. This was done in Tanzania, looking at wildlife, domestic animals, and humans. And here you can see for the ST131 also, you have similar isolates or similar genotypes from humans, from wildlife and domestic animals. And this potentially demonstrates that you have these organisms being shared or transmitted between these different sources. So I'll rush through to what does this mean? It means that we have high resistance to some of these priority, list of critically important microbials, particularly the 3rd, 4th, and 5th generation, the macrolides and quinolones. There is successful transmission as well as persistence of these superbugs, both in and outside of clinical settings. The spread and persistence of these superbugs into the environment beyond human and domesticated animals. There's colonization of both domestic and wild animal populations, which can turn into an infectious source or even a reservoir. And wildlife spread and transmission could actually take these organisms into environmental niches that could continuously serve as a source of resistant bugs. And new putative infection cycles between these different sources, wildlife, domestic animals, and environment and humans, could occur. And of course, this may result into difficulties in treating of these infections. The conclusions we make from these studies, of course, as I mentioned, we have very high resistance to these antimicrobials of concern that will result into more untreatable infections and deaths. And what we want to do in the next coming probably years is to document this burden of resistance onto the healthcare, but also the individuals that get affected by these resistant organisms. And of course, trying to study a little bit more the transmission between environmental niches, animals and humans, but also within the healthcare settings. Thank you, Gladys. I think these are the key issues that I wanted to share. I will keep off the rest of the slides. Thank you.
Okay, thank you very much. That was a very good presentation. It needed more time. You went over time, but it was very interesting. We didn't want it to end. Yeah, I note the issue of wildlife being affected as well. And that really comes about with wildlife ranging. When the interface between people, wildlife, and livestock increases, either outside or inside protected areas, then they can also get into contact with antibiotic-resistant bacteria. The next presentation is by Tabitha Kimani from Food and Agricultural Organization. And this is a session that has Tabitha, Dr. Moodley, and Dr. Adrian Muwonge from University of Edinburgh talking about global regional outlook of AMR. Thank you. Tabitha, you don't have any more than 8 minutes. Shall we say 7 minutes? Because it leaves more time for discussion afterwards. Are you ready?
I'm here. I'm having challenges to share. Give me a few more minutes.
Okay, then to save time.
I'm just going to see if I can share my screen. This is what I look like. Hello, everybody. Greetings from Nairobi. I'm going to turn off my to save bandwidth. Okay. Can you confirm that you can see my screen?
Yes, we can. Can you put it in full screen?
Excellent. Perfect. Let's dive into it so we don't waste time. So I'm going to talk to you a bit about what we're doing here at the CGIAR. And I'm going to focus particularly our activities, both what we're doing across the board within the organization, but then focus directly as to what we're doing in Uganda. So I lead something called the CGI-AMR Hub, which was established in 2019, particularly for health. This is what the pillars of the hub look like. You're welcome to go into our website to learn more about the different research. But I like this figure here. These are the main leading partners we have within the hub and how we cover the AMR in a One Health perspective, looking both at human health, the agricultural and livestock, at where various studies in order to inform increasing the awareness as well as delivering training, which was primarily done by the Swedish Agricultural University, who led the initiative under the CRP. But what came next after CRP Livestock is something that we affectionately called BUILD, and you've heard about it in the video that the VSF Germany team had put out. AMR is one of 4 thematic areas, and this is a program that is co-led by Maif and Ilri. And the AMR component specifically is co-led by Merab Acham and myself, and we focus in this particular research project on the poultry value chain. And this is primarily in Wakiso and in Soroti to give 2 contrasting areas in terms of production. These are all our partners at the bottom. And in terms of Build Uganda and the AMR component, we started in 2019, but thanks to COVID, everything has been delayed. And currently where we are is at this point here. My team is in the field at the moment in Wakiso, trying to collect, visiting numerous farms, trying to understand, well, how are drugs being used, why are they being used, as well as what is the prevalence, and not just, you know, picking one E. coli, but trying to understand how much resistance there is on a farm, which I think is rather important. And so other studies that we plan on doing is a cross-sectional study at retail markets. This is really one thing is what happens on the farm. The other thing is what is the closest to somebody putting the chicken product in their mouth, and avoiding going into their homes. We're looking at retail. What are then the risks, the AMR risks in terms of residues and prevalence at that point? And then we have a longitudinal study, which we're hoping to do that will be 9 months long at the end of next year, looking at these dynamics on the farm. How is resistance changing over time in different production cycles? How is drug use changing in terms of the different seasons? And then the sort of the more mapping of transmission pathways. And all of the information gets fed into to our partner VSF Germany, who then utilize it together with what they're doing in order to understand, well, what can be done in order to increase awareness as well as increasing the knowledge amongst key stakeholders. But also, I think the data that is produced together with MERAB, we get to sit down and see, well, how does this inform your national action plan and help you in terms of prioritizing AMR and investments. Together with this program, in this program, and another program led by ILRI called Aruga, which is a One Health Center, we have engaged a company called 17 Triggers, who are currently working in Uganda, particularly in Wakiso. This is a behavior change lab using what is called human-centric design to solve problems. And basically, we contracted them in order to look at the sort of the social, essentially with AMR and addressing AMR, it's about changing a behavior. And this is what they do, is that they try to understand what is the current behavior and what are the influences, what is influencing that behavior. And at the same time, we try to look at, well, what is the desired behavior that we want in people? And then look at, well, what structures or systems have to be in place in order to support these individuals to implement the desired behavior. And particularly here, it's really about understanding the context of the different farmers, what is driving what is rather their decision making, and at the end coming up hopefully with something is what are the strategic behaviors that need to be implemented, ultimately leading to a reduction in imprudent antimicrobial use. They've just started, and I'm really excited to see what they come out with. Lastly is a new project that we are currently developing that will start in 2022. It is something called the 1CG One Health Initiative, and Uganda is one of 7 priority countries. It is a One Health program that has a funding of $30 million US, and it's supposed to be implemented over 3 years. And the thematic areas are zoonoses, food safety, AMR, the environment, and lastly about economics, governance, and behavior. And typically, and specifically in the AMR part, I want to focus on the environment. As we just heard, it's a sector that has been neglected but needs to come to the table. Gender, policy, and cost-benefit analyses. So these are sort of the things that we are going to build on what we have currently done and other people have been doing and generating data, hopefully then to move to the next step about, well, how can we go about addressing the challenging problems that AMR delivers? What I like to say is that, you know, when we think about how we address AMR in the agricultural sector, I think we need to be mindful of the unintended consequences. The agricultural sector is very important in terms of livelihood and delivering food and nutritional security, as well as in terms of addressing gender and youth inequality. And at the same time, we have to be mindful that with coming out of COP26, the UN Food System Summit, is that we have an intensifying food system. But these systems need to be, you know, considered for where they are placed and the informality and the local context, as well as the environment, the greater environment that they fit in. And how then do we put in AMR and address AMR while balancing these two needs of improving the environment, as well as at the same time maintaining livelihoods and food security. And all of this really pegged on the UN sustainable goals. And so what I always say and continue to say, and I think
you have to summarize.
Few slides left, is that I think the interventions need to be locally relevant, context-specific, cost-effective, and sustainable. AMR is not going to go away. We are not going to eradicate it in the next 5 years. It is a lifelong management or control. So those interventions need to be sustainable. And all of this peg against mitigating global health threats. And that's what I tried to indicate here. And my last slide is that it's not about doing it by ourselves, it's about working together, because that's what is going to be needed, is all of us pooling our efforts and data and resources together in order to mitigate AMR. So thank you very much for your time. Bye-bye.
Thank you very much. That was a very nice presentation. And hopefully there'll be time to discuss and ask questions later. Tabitha, I can see you're ready. Could you please begin? You've got 10 minutes. No less than, actually try and make it 8 if possible.
Okay, thank you. I'll just discuss a little bit about AMR surveillance, focusing on AMR surveillance and monitoring. I am Tabitha Kimani, working as an AMR regional coordinator based in Nairobi. Let me say that within the region, we have very many AMR projects implemented by different partners, particularly the tripartite. And that is a map showing where a lot of projects are and where we don't have projects. And basically on the left is where most of these projects are focusing on, and you can see Uganda is part of this. So let me say that globally, there are a lot of efforts to trying to harmonize AMR surveillance and also bringing all the data together globally. And so the tripartite is working on the integrated surveillance system for AMR and AMU, and we do have shared responsibilities where FAO will be responsible for collecting AMR data and reporting globally from the agriculture sector, and also AMU from plant health, while else OIE will collect AMU data in animal health, and WHO will collect both sets of data from public health. And this arrangement also mirrors what is happening in done is building on what Asia has done. They have come up with regional AMR surveillance guidelines, which reflect the priorities of the countries. So these guidelines are almost being finalized, and we do have the SOPs that have been compiled. So the picture on your left shows the guidelines that we have adopted from Asia, and on your right shows the current guidelines that we have for Eastern Africa. So what we have done is we noticed that countries have different stages in terms of development of their surveillance system. So we have defined what could be the entry points for initiation, and also what are the targets for regional harmonization. Let me say the starting point will be, aggregating data from broiler chickens, and also touching on E. coli, Staphylococcus aureus as the starting point, but also later bringing on board Salmonella, Enterococcus, and Campylobacter. So we define in the guidelines, I'm not going to go into the detailed guidelines, they will be shared later, and once they are available is to give countries the guidelines. So that the guidelines reflect the needs of Eastern Africa, what we have done is we have used FAO state data to look at what are the most consumed animal source foods in East Africa, because these actually represent the source of risk, and therefore should be considered in AMR surveillance. And as you can see, while a lot of other regions will focus on chicken, pig, and dairy, I don't have the dairy slide here. You will see that in Eastern Africa, we have cattle coming up very strongly. In some countries, camel is also part of the 3 most consumed animal source product. And even in some 2 countries like, I guess, Ethiopia, we have game meat. And it is interesting because Denis has already highlighted surveillance, resistance in wild animals. So in terms of operationalizing these guidelines, we have defined in Chapter 6 the roadmap, but we have also recommended, there is also a recommendation to create an effective regional coordination mechanism, which will be the AMR surveillance network, we have discussed this as FAO and the regional partners during the actually last week during the Regional Animal Health Network meeting, and this was the recommendation came that we need to start this regional coordination mechanism in terms of and so what we will be doing is we'll be getting in touch with the countries because we have defined what will be the TORs for this network, and you can see them. I'm not going to lead them, but basically it's these guidelines at country level. We have looked at the national strategies and we see some gaps. So it's working with countries to ensure these guidelines are adapted, sharing the information at regional level, analyzing the information and drawing up the regional priorities. That's what the surveillance network will do. And so we recommend the participation from 11 countries, 2 nominees from every country, and of course bringing in the partners that are working on AML, including EURI, tripartite partners, and UNEP, Africa, CDC, and AUEBA, and using the funding of the projects that we have to start the operations of this network, bringing countries to operationalize. So our next step is to get in touch with countries and holding a meeting with this regional network. Thank you very much. Over to you.
Thank you very much, Tabitha. Would like now Dr. Evelyn Mwonge to speak next, and that was a very good presentation. Thank you. It was nice, summarized and brief, and we look forward to the next presentation.
Hello, can everybody hear me?
Yes, we can.
Thank you for the opportunity to speak to you about capacity building. We are playing a role in capacity building in these 3 countries, but my talk will focus on Uganda. And basically the experience of the University of Edinburgh providing capacity building for countries as a Fleming Fund Fellowship host institution. So this is the team that is providing this capacity building to the nominated fellows from the institutions, mostly to reflect the One Health model. Basically, the fellows are nominated from the Ministries of Agriculture, the Ministry of Health, and some come from academia. So as part of this program, we're tasked to provide a comprehensive capacity building package tailored to the fellow and the needs of the settings where they come from, with the hope that they then support the implementation and the evaluation of the national action plans within those countries. We have 3 countries, Uganda, Malawi, and Kenya, and the photos you see there are of the fellows who are nominated from these countries. In Kenya, we have just 2 fellows. These are policy fellows. In Uganda, we started off with 6 fellows, as highlighted. As I mentioned, these come from the 2 ministries, as indicated. But they are also selected to reflect the 3 pillars of the Fleming Fund Fellowship. That is AMR Diagnostics, AMR Surveillance, and AMR Stewardship. And so later on, we received another cohort of fellows. These are policy fellows and professional fellows. And the selection of the fellows is really similar across the countries. But my talk will focus on Uganda, and just to note that by the end of 2023, we will have provided capacity building to 19 fellows in this region. So our training program really starts with a needs assessment that is led by the fellows within country. And this allows us to identify the needs for the fellows themselves, but also the institutions where they work. And so then they start off with training including quantitative and qualitative skills, an introduction to the sociology of AMR, because as discussed, really this has a very huge behavioral component, policy writing, media communication, a whole package that rounds off these experts who are supposed to support the National Action Plan. They then participate in a collaborative project. This allows them to work as a One Health team, really focusing on their expertise within a specific component of the project, but put together really represents a One Health project. And here we really had a very significant input from social anthropology, and as you will see later on, this was quite helpful. Now, the evidence that comes from this collaborative project then is supposed to allow the fellows to write a policy brief for each of their institutions. And so all the institutions that are here, I really would encourage you to remind your fellows to provide you with this policy brief. Now, these three components then contribute to the development of the blueprint for the One Health surveillance plan for the country. But on the other hand, also contribute to the continuity of the training through the policy and the professional fellows. Now, all the cohorts then will contribute to the update and the review of the national action plans, which is coming up really soon, in I think 2022 for Uganda and 2023 for the rest of the countries. So this collaborative project is really the chance for the fellows to put to action this national action plan strategy that they're planning. And in Uganda, the fellows focused on a condition that was identified as part of the needs assessment, and this is bacteremia in the hospitals. So the question the fellows had, really, what is the role of the household and the livestock in the communities in the AMR epidemiology that is seen in bacteremia conditions in hospitals. So we selected 200 cases from 2 referral hospitals in Jinja and Mbarara, and followed them back into their households, sampling other individuals in those households and the livestock if they did have livestock. Now, as well as metadata. Now, to link the household to the community, we also ran a cross-sectional study where the same data was collected. Here, of course, a nasal swab for Staphylococcus and a fecal sample for E. coli. But also mapped all the outlets where antibiotics are sold, and also the characteristics of prescription within those outlets, as well as in the referral hospitals. So putting that data together really should allow the fellows to understand the contribution of these components to the resistance you see in the hospital, or between the components. And just to show you some of the results on how antibiotics are consumed in hospitals compared to communities. From the prescription records that we reviewed, we were able to then calculate the defined daily doses of antibiotics, which then allows us to compare between these two hospitals. On the right hand, on the y-axis is Mbarara, on the x-axis is Jinja. So you really can see that there are antibiotics, which is similar to what Denis has talked about, that are used at par, really high, but almost in equal proportions. And then, really by far, the beta-lactams are the most used antibiotics. But the picture is not different in the communities and the households. The same antibiotics are used. We note that the macrolides are quite used in the households and in the animals, and it will be interesting to see what the proportions of resistance for macrolides are in the communities and in the hospitals. But then if we contrast this with the resistance that we profiled for this list of antibiotics, the resistance profile is really not any different. So if you look on the x-axis, that shows you the proportion of isolates in the hospital and in the community that were resistant. And as you can see, the proportions are similar, not just in the hospital, in the animals, and in the humans in the communities, but also especially in the districts. That is true for these third-generation cephalosporins, true for the fluoroquinolones, the phenicals. The picture really simply shows that, and these are should be treated as preliminary results, but they show that you have this incredible overlap in terms of the proportion of organisms here, sentinels, that are resistant in the cases of bacteremia and in the community households as well as in the households. This also mirrors the use of antibiotics. And so also this maps directly onto the pillars that are designed for the training, which is diagnostics, surveillance, and the stewardship. So as part of what we think this has contributed to the delivery of the National Action Plan, we have trained the human resource that we hope will directly contribute to the implementation, review, and review of the National Action Plan. We are aware that most of these fellows are now part of technical working groups, some of them within country, others regional, and others contributing directly to the WHO, FAO, and OIE. So in this regard, the fellows are directly exercising the skill sets that they have acquired. I just wanted to tell you about two stories. One is the gentleman you see there is called Mr. William Olum, and he's the chief pharmacist for Ginger Hospital, Regional Referral Hospital. As part of our training, he has developed an antibiogram, which he's been using to guide their stewardship program. And this has become quite popular, that other referral hospitals have now started sending their pharmacists to learn from William. William is also now invited to other hospitals, but he also now sits on the committee or the subcommittee within the National Action Plan responsible for stewardship. So we think that's really a pathway to change in clinical practice. The second is the photo you see there is a group of veterinarians who had spent a week at the Ministry of Health looking at how to standardize these AST tests. And these meetings, some of them were part of our studies, others are part of funding from elsewhere, but they are instigated by our fellows. And so we really think this is, or believe this is One Health in practice. So thank you very much. We believe that capacity building is really needed because really the implementation of the National Action Plan requires a dedicated team that does the job. Thank you for listening.
Thank you very much, Dr. Adrian Mwonge. That was a very nice presentation. Very interesting things you're doing with the fellows. We quickly move on to the next speaker, Professor Melissa Parker, and I'm also going to hand over my moderation chairmanship to somebody else. We look forward to the next presentation on AMR and social science. Is Professor Parker ready? Hello, is Professor Parker ready?
Well, glad as I can.
Is Professor Parker ready? I don't seem to She on? I don't think she's on. Well, if she's not on, then let's have the general panel discussion. Let's have a Q&A. Does anyone have any question? Yes, Ashley Moodley, could you please speak?
It's just a question that I noticed in the chat is about how we communicate the results that, acknowledging that so much work or research is going on within this field, but how to communicate that to either the general public or necessarily or to policymakers. And I think that that's such an important question, because I think as the scientists, we tend to get carried away with the nerdy bits because we love it. And sometimes, AMR is such a complex problem. And in order to simplify that to the public is a challenge for people like myself. And that, this is where I think communication experts are really needed in digesting the information that we generate and trying then to deliver that to the different stakeholders. Because I think each package of information has to be adapted to the needs or a particular priority group, a group of individuals. And I think that that's always the challenge with science and communication. And particularly now in COVID, I think we're seeing how we communicate science to people who are not necessarily scientists. I just wanted to highlight what I read.
Yep, I think that's a very valid point. As scientists, we're not really good at communicating to the general public. And I think there should be some training on how to get scientists to communicate in a very simple way and in an effective way to the general public, to policymakers, people in the government. They don't want to read something which is, a busy minister does not want to read something which is longer than 1 page, 2 pages maximum. The same with the private sector and a lot of other fields. We need to make things as simple as possible if we're going to transform our research into policy or practice. Yes, Denis, Professor.
Yeah, thank you very much. I'm very glad Ashley has brought up that issue of communication. We have a very clear strategic objectives. Strategic objective in the National Action Plan. And just like the infection prevention strategic objective, that has not been actually given attention. One of the things that we recommended was to develop a comprehensive communication strategy for explaining not only the action plan, but also to communicate some of this information. And I think as we review the performance of the action plan, I think we need to pay specific focus to those areas that have not obtained quite good attention. While we as scientists, we generate data, there is a limitation that we have that we cannot be able to communicate this to every audience. We just released the policy brief from some of our studies, but we don't think that is enough. Perhaps some of the policymakers may not even find time to read these. And so unless we have that specific strategic objective quickly addressed, I think we will still continue to generate this evidence, and it's not getting to the right targets or packaged into formats that can be taken up easily by the different audiences. So I want to thank Ashley for bringing that out very clearly.
Yes, and the policy brief training is very good that the fellows are doing, because that's one of the most effective ways of changing research to policy.
And maybe to add, this morning the commissioner just said that actually we seem to be talking to ourselves. When you check on the attendees, these are the same people that we have been talking to all the time. what efforts are being made to make sure that actually we include in people that actually this information actually is supposed to impact? So I think we shouldn't only just probably talk, but walk the talk. Thank you.
Yes, definitely. We should try and invite other people to these webinars who are not necessarily exactly in our field, but are needed to make things move to the next level. Yes, and also media training, by the way. More and more media training is needed. I know the One Health platform is doing a lot of that, but even in AMR, we need to have more media training so that they can educate the general public. Yes, Tabitha?
I think one more additional thing that needs to be done to turn the information into policy is to package the information so that it's for non-technical persons, particularly the policymakers. If I'm sitting somewhere in Ministry of Finance and I need to finance AML, that data that says we have a 72% something resistance to 10 antibiotics, that information needs to be packed in data that I can understand. What does it mean in terms of livelihoods? What does it mean in terms of how many people are dying, how many people are getting sick, the economic data, the figures, because that is the language they understand. We need to move that data from those technical figures to what it means in terms of impacts to those policymakers in a way that they understand it, so that now they can say, yes, we have a problem here. But if you just tell them that technical information, they can't comprehend it. Over to you.
Yes, definitely. You're right. It needs to be broken very simply so that everyone can understand it. Thank you. Any other questions? It looks like there's no other questions. What about from any of the other people who are not panelists necessarily? Okay, it seems that there's no more questions. The session has gone over, but at least I think we've all really enjoyed it. And the presentations are going to be shared with all the people who registered. Actually, there's an email to send it to if you'd like a copy of the presentation. You can send it to Dr. Christom Ayeziwe and Susebunya, and so that you can get a copy of the presentation. Otherwise, oh yes, there's one more. Yes, Dr. Jessica Nakabuma. Please go ahead and ask.
Thank you very much, Dr. Kalema. I just wanted to bring to our attention that there are two attendees whose hands are up, Jackson Twebaze and Barbara Natif.
Ah, okay. How come I can't see them? Okay. Okay, I have to look at them in the general participant. Okay, because I'm looking on a different link. Okay, Barbara, could you please ask your question?
They need to be unmuted, I think.
Okay.
Or they better
Attendees. Okay. Let me see if I'm able to unmute them. Barbara. Yeah, they need to be invited. That's the problem. Yeah, that's the thing about this platform. Not everybody can participate equally. Barbara, could you please put your question in the chat, and Jackson Twebaze as well? Please put your questions in the chat. Yes, Barbara.
Yes.
Uh-huh. Please.
Yeah, thank you so much, Dr. Gladys. My name is Barbara Natif, and representing USAID Social and Behavior Change Activity. My question is related to the presentation made by Dr. Ashley. And Dr. Ashley, you mentioned the fact that you will be rolling out a project called 17 Triggers that is involved in pre-testing SBC interventions through a laboratory. I want to find out how this project, what is the scope of the project, and what has it carried out any HCD interventions? How can we access some of the findings from the HCD interventions in order to scale up message development for AMR? Because I've observed in the meeting that communication is very critical. So how can we build synergies with 17 triggers to enhance SBC communication around AMR? Thank you very much. Over.
Thank you very much, Barbara. So it's a fairly new project that actually just started here in August. So we are currently in the phase of developing, well, firstly trying to understand what are the challenges that farmers are facing and what is the context of these problems. And based on, so we have already also developed a checklist of different measures that we think could be relevant for a farmer to implement. And based on that and the current research and trying to understand the context, the next step is then to marry the two together and come up with something that says, well, these are the prioritization that need to be implemented, thinking about reducing AMR and whether or not they're feasible. So we are still, it's a fairly new project. You're welcome to write out to me and we can, get in contact. But for sure, as soon as 17 Triggers have anything to share, I will definitely be sharing it with my Ugandan colleagues and happy to share with anybody else that's interested in this kind of work. Thank you.
Thank you. And then could Jackson ask his question? And I'll probably have to leave and I'll hand over to Dr. Chris to complete.
Yes, hello?
Yes, please.
Hello?
Go ahead.
Yeah, goes to Professor Denis. I liked Professor Denis' presentation because he was showing us the findings that he has gotten from the research carried out on the African setting, especially here in Uganda. But I would like him to compare and contrast the findings that has been also been documented from the European countries, because for them their systems are a bit more stringent compared to ours, to see how far, what extent antimicrobial resistance has gone compared to our setting here. And we see if there is what we have not done well, what we can be able to do well or much even better. Thank you very much. Thank you.
I think that is noted, and we frequently do compare notes when we are viewing literature. So I think we can share more about this separately. Thank you.
I think the session has come to an end now. We've got all the questions and answers, and thank you all very much for being part of this session. And I think it's come to an end. But if you'd like to continue speaking, I'm handing over the chairmanship to, I think, to Musa. Will you take it up, or Dr. Chris Izibire? One of you should take up the chairmanship.
Thank you so much, Doctor.
Okay.
I'd like to give a brief update. The second person, the first panel has already finished. They participated in the morning session. Yeah, thank you so much. Sorry for the echoes. Members, I was just communicating that this first panel that we are going to after led by Dr. Winnie, it was a panel which was participating in the morning on the breakfast meeting. So now we are left with one panel which is going to be moderated by Dr. Jessica Nakavuma on research and training, and it's where we are going next. So I would welcome Dr. Jessica to take us and lead us through this session.
How the arrangement was. So do we have representatives from these various institutions who are going to present to us? I need some guidance there.
Thank you, Doctor. Okay, now I think I'm heard. We wrote to each of these institutions, and they are supposed to send us a representative who is going to give a brief. Like for Mbarara, we have Joel. Under Makerere, we have not received the nominee, but Mbarara we have received, and we thought that in this session they are going to present on research and what they are doing as per AMR. Yeah. Finish? Iliri? Finished? So we are left with the Iliri and IDI, they have finished presenting. So we are left with the mainly Makerere University, Naro, you said medicines, the MTAPs. I don't know that Dr. Dick Soka is online. College of Vet.
Dr. Joel Bazila and Dr. Dick Soka. We can start off with them, and since some have gone off, think I'm giving you like 8 minutes to present to us in order to get to beat time.
I think Ilil is available. Yes, I've seen it.
So has his hand up. Dr. Joel. Jackson, you seem to be talking, but the voice is not coming up. Dr. Joel, can you please start? I can see your hand is up. Maybe as you prepare yourself, I just give some little background because we can appreciate that AMR is quite an issue that is greatly affecting global health. And if we are not at these lower levels, if we are not training the necessary person, the people who will take up positions where they have to fight AMR, then we are doing a disservice to the nation. So the training institutions, the research institutions should gear up or revisit our approach to ensure that AMR is really addressed and the students are made aware of it. So Dr. Barbara, you have a hand. I don't know whether it is from last time. Hello?
It is an old hand, sorry.
Okay. The internet connected. Come again.
Is it lowered now? I think it's
okay. It is better now.
Okay.
Okay, it has been lowered. Dr. Joel Basila, please, is he around? He was. I saw his hand, he was up, but.
Yes, hello.
Yes, please, Dr. Joel, please go ahead and present to us what is taking place at Imbarra University as far as AMR training and research is concerned.
Okay.
Maybe the plans that you have.
Okay, thank you very much for giving me this opportunity to share a few thoughts about AMR training and research from the Emr University perspective. Actually, when they invited me to talk, they just said I'll give brief remarks. So I didn't actually prepare a PowerPoint. So you will forgive me for that. I am grateful to the organizers for giving us as a team an opportunity to share what we are doing from this side of the world. My name is Joel Bazira. I am an associate professor in the Department of Microbiology at Emr University of Science and Technology. I've also been a fellow, Fleming Fund Fellow on Human Health, Emr Surveillance. I think you saw some of the results of our work that have been presented by Dr. Adrian. I worked together with Merab on the surveillance aspect. She was doing the part in animals and I did the part in humans. And I also helped to culture in my lab the animal samples here in Barara Microbiology Lab. And yeah, on the part of research, we have been gratefully funded by the Fleming Fund. I'm part of the country grant as a partner together with DMM Makerere and COVABS and I think Pharmacist School to be able to do surveillance at in the hospital. we did on country grant 1, surveillance, passive surveillance in the hospital, and also supported Kabale Regional Referral Hospital with a bit of training and supervision. And under country grant 2, we are working on surveillance in high-risk MDR units, and these will include the cancer unit for both children and adults, surgical units, where we'll do pus and wound swabs. There is a nutritional unit, and we hoped also to work in the ICU. That work should have taken off by today, but there is a strike for doctors countrywide. So it's been a bit left behind a little bit, but that is what we are doing on the surveillance side. And we have also supported, together with the Fleming Fund, supported the hospital and the MTC unit of the hospital. MTC is the Medicines and Therapeutic Committee of the hospital. This is the committee that decides on the drugs that the hospital is going to buy. And the Fleming Fund is directly supporting them on the stewardship side, and we are providing the surveillance data that will basically help them as they make decisions on which drugs they are going to buy. The Fleming Fund has also agreed to renovate our microbiology lab at the university to make it probably a standard microbiology lab, so that we are able to continue to offer a good service. On the other side, because we're in the same campus with the hospital, the Fleming Fund has equipped the hospital lab with a blood culture FX, I think it's FX100, FX200, to be able to improve blood culture. There have been efforts to train laboratory technicians and mentor them. Unfortunately, due to funding issues, the program for the lab tech support has stopped, but we are waiting on the IDI, who is the consortium partner, to tell us on which way forward. One of the challenges that we have found is that not many people want to do microbiology work because it is mostly manual. Many technicians keep running to just the hematology and the other aspects, which are just easy to do, and they are, most of them run by machines. On the training side, we have managed to train quite a number of students. We have, in our department, we have a program, a Master of Science in Medical Microbiology, where we train technicians and other people. We've trained veterinarians, we've trained lab techs, we've trained doctors in medical lab. We also support the other training programs in the Master of Medicine programs, where we train them we run a short course in medical microbiology, and we actually emphasize to them to come to the lab and actually do hands-on. You know, they pick up a sample and analyze it to the very end. And that, for many of them, is a new experience and helps them to appreciate the role of microbiology in helping them make decisions, but also helps them to understand on how to use this information which they receive, because many of them think if you send a sample today, you receive results tomorrow. And if the results don't come, do empirical treatment forever. But when they go through that process, they appreciate how long it takes to come up with a result. And therefore, that improves a bit of the usability of results, because that has been part of the challenge, that microbiology results are given out, but their usability is always a challenge because of the very poor turnout. It still goes to the MTC. Recently, I had a meeting with the MTC of the Regional Referral Hospital, and I was emphasizing to them that one of the questions I usually get asked when we present data from microbiology, culture, resistance data is, do the people in the hospital actually use this data? And I put it to them and I said, we need to find a way to make use of this data that we generate in the hospital. And in attendance was the director. He gave lots of excuses, and guidelines take time to develop guidelines, but I mean, I think we need to continue engaging these people from the ground root to be able to see that whatever results we come up with are put to use properly. On the other side, with our technicians, we've been brought on board. Some of our technicians and some people in the department are national trainers. They participate in training of lab technicians. We've participated in the development of the in-service curricula that is going to be rolled out to train lab technicians in microbiology techniques. We have also contributed to other documents, the surveillance plans as a department. We've also had other students. We run graduate programs, this time not just as a department, but as a university. I personally supervised the PhD student who was working on the quality of River Rizi water. River Rizi is probably the longest river in southwestern Uganda, and most of the water that we use actually comes from that river. And we did microbiology on that river, and we really found quite a lot of resistance in E. coli. And we're trying to really now purposefully go for that a little bit more. I think for now, that is what I can share. And maybe lastly, our lab at Mara University is a training site for many lab training schools. Many students come through our lab to train in microbiology, and at diploma and at certificate level. So thank you so much for listening.
Thank you very much, Dr. Basila, for that snapshot of what is happening at Mara University. If you have comments, questions, please note them down or just put them into the chat or Q&A to enable us a bit time and handle at the end of it. The next one, did we get anyone from College of Health Sciences? Do we have someone from College of Health Sciences? Or COVAB? I thought I would finish with the universities and then go to the institutions. Hello? Do we have a representative from COVAB or from College of Health Sciences, Makerere University?
Hello? Yes, doctor? Sorry, I've got a feedback from a few members. They are saying that because of time constraint, some of them, they thought they will present earlier than this, and many of them have left. So I was requesting that since time has caught us, maybe we get remarks from you, and we conclude the session today, as most people who are to present now, they are the other engagement, and they have been engaged already. It's a request, and we are so sorry for that. And some have just been following up, and that is the response. Otherwise,
I thank Dr. Joel Bazila for the presentation. It has given us a snapshot of what is happening. There is research that is going on. There is some surveillance activities that are going on. And for the training, it has been general. It seems there is no like short course for that is focusing mainly on AMR. And from my experience, we have these curricula, but the topics on antibiotics and antimicrobial use are usually very brief, especially at undergraduate level and even graduate level. So unless a student carries out research on AMR, that's when they get more information. So maybe there is need to embrace, there are some online training courses that we can recommend to our students to undertake in order to get to increase their awareness, their understanding of this antimicrobial resistance, the principles, the impact. So other than the crossover that we usually deliver. So there's the online courses that exist. There is the WHO Health Workers Education and Training on AMR, and there is the Global Health Learning Center, which has some AMR courses. And then we have the Framing Fund online AMR courses. Most of these courses are free, so we should, I think, encourage our students to read them. And maybe also we come up with the hours that can be recommended for the in-service and our students as well. And when it comes to research, so from what has been presented, we are looking at the prevalence, we are looking at resistance mechanisms, and it's not yet done in a systematic way, or probably we may not be able to report our findings to those global bodies. So maybe the gaps that we have should be that when we are carrying out research, we see that we are fitting within what the surveillance plans for the countries are recommending, and also look at we get the research gaps. What are the trends? Do we fit within the newly developed surveillance plans? Is there data, reliable data on mortality, morbidity attributed to AMR organisms? What the prevention and control has been highlighted as one of the major means of managing AMR. What is it that we have, and what should we do, and what do we need to do? As well as the economic impacts and costs, probably that's where we can convince the policymakers and the government to come in. When we bring out the economic impacts and cost, all those are researchable areas that we should look into in order to fight this AMR and to get more funding opportunities. As we can see that being a global, a threat to global health, there are very many funding opportunities available, but we should not only get prevalences and maybe resistance mechanisms and end there. So we need to get something that should convince the governments or the policymakers and the local funders or the ministries to come in. I think that is all I can, the comments that I can give to go as a discussion or a bit of contribution to this particular session. So if there are members who have who had questions, given the circumstances, that time is not on our side, I think they can just post them and they will be attended to by the respective person. But we only had Dr. Bazira who presented. I thank you very much. I hand over back to the organizers. Hello, organizer, are you there?
Yeah, thank you so much, Doctor. That was so wonderful and timely. Members, thank you so much for participation. Thank you presenters all for presenting. And we are so grateful. We are heading tomorrow, a day which is mainly going to be an interaction between us and the media. We have a panel on media, and then on practitioners, and then the regulators. So those are the three main panels for tomorrow. And the practitioners together, the farmers are willing and will be on call. We will have regulators on call. And then the media. So tomorrow it's another day that we have prepared, and we hope to start on time at 10 without fail, because we are going to be finishing early by midday, and we head to Masaka for the national celebrations, which are going to be held in Masaka on Wednesday. So members, tomorrow we are requesting for timely start so that we could all finish on time and have the members present under the panel discussions on the different teams. Thank you so much. At this time, I would welcome Dr. Chris to close for us for today as we wait for tomorrow. Thank you. Doctor, you are welcome.
Yeah, good evening, everybody. Yeah, just to say thank you for honoring this invitation. We are sorry for whatever didn't go very well. As you know, multi-sector coordination requires patience, but nonetheless, it was a success. We pledge to continue working together with the government and different partners to ensure that the work of AMR and MU is a success. So without wasting your time, I wish to say thank you and wish you the best of this evening. Thank you, best regards. See you tomorrow at 10. And that one will be virtual completely. Thank you.
Please, we are using the same link. And the speakers, we may not be virtual tomorrow. Some members are going to be in Masaka, others are in Maif, others in Health, and will be virtual and totally. So those who are supposed to come here tomorrow at Imperial Royal, I request that will be at our locations, and the meeting will be entirely virtual. Thank you so much.